when I'm worried about 10,000 things while I'm looking at that patient, and let's say I only have 2 COVID patients, I'm worried about their well-being. I'm worried about not being able to bring their family to talk to them and see them. I'm doing FaceTime. I'm also worried about who's going to take care of my kids at home and my neighbors who are suspicious of me as a healthcare worker, that I'm going to bring the disease to the neighborhood. All those factors don't go away when you go to work.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Dr. Salah Qutaishat, infectious disease epidemiologist, and we're going to be getting his unique perspective on the purpose of regulatory agencies and surveying bodies and whether or not they are truly connected with the front lines, the nurses that are providing the direct patient care, and do we have a patient focus to improve patient outcomes. So I'm really excited to get into this episode. I had a chance to speak with Dr. Qutaishat before this interview, and I'm really excited to share his unique perspective on healthcare and infection control. We're going to be right back after a short break with Dr. Salah Qutaishat. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Salah Qutaishat, infection disease epidemiologist at International Infection Prevention Group. And Salah, I got to tell you, before we even get into this, you're one of the most dynamic people I've had the pleasure of speaking with over the last few months. We had a chance to connect for the very first time, and a prior guest of ours, Mark Oliver Wright, recommended that we have you on the podcast, connected us, and here you are today. And you're going to touch on some things that I think are really important, and it's going to talk very much about regulatory agencies, and that's a pretty broad sort of definition. So we'll define that as we go through the conversation. But these regulatory bodies and the need for improvement to just continue driving the industry in the right directions, right? And one of the things that you've made known to me on both times that we've spoken, including today before we started the podcast, is just how overwhelmed infection control practitioners are right now with the current state of the environment, limited access to data. And I know as an epidemiologist, that's a big part, right? Is having the data to make these decisions. And so it's going to be so great to talk to you today. Thanks for coming on the show.
Thank you. I appreciate the invitation and I appreciate the introduction.
Well, I've been very excited for this interview, and partly because I knew that you and Larry would find, a lot of commonality as well, just in the way that you evaluate the current state of things. But I think everybody's familiar with Larry from all these other podcasts, but let's familiarize them with you and your background. Can you just tell us a little bit about yourself?
Yeah. So I struggle when I say I've been associated with healthcare for more than 4 decades because it makes me feel that I'm older. But I've seen healthcare evolve. And I've seen the science evolve. And I date myself in the US to the AIDS pandemic. But I spent years in laboratory medicine. I also spent years in academic centers, and I did university teaching. And then about 20 years ago, I moved and I'm trained in microbiology. So my really bread and butter is microbes. I moved into infection prevention because of its association because the close link between microbes and humans. And I always believe that there is a way to prevent transmission of infections, but also we need to have a peaceful relationship with microbes. And that's my philosophy, is that it's not about killing microbes. It's about making them live in their normal habitat, happy, and also they're beneficial. We know I did a podcast on the benefits of microbes. So when I moved to infection prevention about 25 years ago, it was early when there were regulations about prevention of transmission of HIV to healthcare workers and TB. That's the early era of making infection prevention as a real entity in healthcare.
It's interesting. The first thing I think of when you talk about the microbes and having them live in their normal environment and not move into areas they don't belong, I think immediately of Staph aureus, and I think of Clostridium difficile and the normal flora in the GI tract. And, you're right. It's when they get into the areas they don't belong that they start wreaking havoc. It's almost like an invasive species like we hear about in the lakes and streams across the country. So you did a really nice job of kind of describing that in a different way, one that even people outside of infection prevention could really grip onto what you mean there from the theme, right? Because they do have a place. Without them, our bodies will also be vulnerable because one microbe will just go in its place, and that one is one that doesn't belong there either. And so very well done. I know today we're going to be talking about, regulatory agencies and surveying bodies. And so it's pretty broad sweeping. But when I say regulatory agencies, I'm referring to, like the FDA. And when I say surveying bodies, I'm talking mostly about accreditation organizations, like the Joint Commission or DNVGL. And I kind of wanted to get your take because I feel like it might be a little bit of a gray area, but where does the state, the Department of Health fall? Are they somewhat a little bit of both in that regard, or are they very much more on that surveying kind of side?
So an interesting question, because I think accreditation agencies, in my mind, lost their focus. They became agents of policing rather than improving outcomes. So when you look at the structure in hospitals, and I focus on acute care, but this also applies to any healthcare facility that gets accredited. The focus is always the patient and the well-being of the patient. So the intent is the right intent. The execution, in my mind, diverted resources and energy into volumes of requirements that are detached from the real world of patient care. So who takes care of the patient? That's really the biggest question in my mind. It's neither the Joint Commission nor DMV, or the state actually acts on behalf of CMS for accreditation. They're not the ones that are close to the patient. So we're actually putting pressure on the key people, and I'm going to actually be very specific and maybe biased when I say providers, physicians, and other support staff. Nurses are the key players in patient care. There are other entities that do that, pharmacists and others, respiratory therapists, and so on and so forth, the laboratory. But those are the key people, the closest to the patient, the ones that touch the patient all the time, are the key players in providing care. When we look at all the accreditation agencies, it's almost, in my mind, and this is my personal opinion after years of being part of, on the receiving side of surveys, there's a disconnect between the regulations, the requirements, and the actual patient care provider. Most of the conversations about compliance with requirements, and they're called requirements, are hardly discussed with the ones that touch the patient. So that's where the disconnect. The key is, in my mind, is that people that touch the patients are the ones that are going to improve patient outcomes.
So, Salah, I want to tie a couple things together that you just said. So we talked about the infection control practitioner being overwhelmed today. And so they're being pulled off on some COVID-19 related tasks. We're also talking about regulatory agencies and surveying bodies. And you mentioned in surveying bodies this issue of them policing. And I want to focus on that a little bit. With infection control practitioners kind of being pulled away from what they ordinarily would otherwise be doing, which would be per the conditions of participation with Medicare, where they would be focusing more on surveillance and monitoring infections. The issue comes up as to whether, at least in the last 2 years and prior, you can talk about both, do the accreditation agencies, are they really policing? In other words, are they really overlooking and reprimanding if there's significant deviations that could pose an infection risk? Or instead of policing, are they using a different paradigm that the public may not be so aware of, where they're really working with the facilities that they are overseeing rather than policing and having some type of authority over? So can you talk a little bit about that in the COVID-19 pandemic as to whether we have really placed in the back seat the patient safety issue because we really can't comply necessarily, or maybe we can, I'd like to hear, with the regulations that state, in short, that hospitals really have to maintain a clean and sanitary environment to avoid the sources and transmission of infection. Are we doing that today in the COVID context, and are we really policing, or are we not?
That's a great question, Larry. Sometimes my smile is the nervous smile. When I laugh, it's a nervous laugh and laughter. People don't understand that when I do that. They think I think it's funny. It's not. I'm nervous. The past 2 years, I want to give you an analogy. A continuous hurricane hitting a town, or a tornado that never left. So if you use that analogy, and it's the truth, actually, that tornado hit and got quiet for a little bit and hit again, went to the other town, came back, hit again. So for infection preventionists, it became more, and also that hurricane or tornado is something that we've never seen before, or we've ignored that we've seen it before. We were never prepared for this magnitude of a pandemic. So what we did in healthcare, we reacted and we tried to adapt, and we dropped, because of the volume, it's that magnitude. We dropped all other kind of activities because we're focused. We don't have the resources to address this big event. So we dropped everything. And there's a paper that came out recently that healthcare associated infections increased during the pandemic, which is normal. And it's not just infection prevention.
But why, when there's less people in the hospital, right? If you're canceling all these procedures, right, and you're only treating the people who absolutely have a necessity to be in the hospital, why would infections go up?
As the number of procedures drop, correct?
Yeah. It's really shift and focus. And I think we always ignore me. As a healthcare worker, I am also concerned about me and my well-being. So that we almost ignore that. We look at the volume and say, okay, we have less people, but the stress level is high and continues. This means that we have more time. No, because the magnitude of work and the shift and change and the pressure, the pressure on healthcare now and for the past 2 years really shifted the focus, and they're still in a state of shock. If we, and I'm not trying to rationalize or justify, but I talk to my friends. I feel their pain. They're all struggling, and
with
everything
fear
is
and
changing.
uncertainty, right?
Absolutely.
So whatever there was in workload reduction, the emotional hurdle and stress and all of that we know leads to higher error rates and less, efficient performance, kind of fills that gap. Is that kind of what you're saying? Like because of the high stress situation, you still have this complication of being understaffed, and we've shifted the focus onto something singular. So they weren't taking care of this over here. And even with less patients, we replaced that space, that mental energy and focus with the concern over self that I would say, being a nurse myself, the martyr syndrome has us put in check most of the time until we are hit a breaking point of fear and uncertainty where all of a sudden we become primary again. We're not a martyr anymore. We're scared for our survival and what that means for our family. Is that true? Am I characterizing your point well?
Yeah, I agree. And I use analogies all the time. When my brain has its own capacity. When I'm worried about 10,000 things, while I'm looking at that patient, and let's say I only have 2 COVID patients, I'm worried about their well-being. I'm worried about not being able to bring their family to talk to them and see them. I'm doing FaceTime. I'm also worried about who's going to take care of my kids at home and my neighbors who are suspicious of me as a healthcare worker, that I'm going to bring the disease to the neighborhood. All those factors don't go away when you go to work. You don't just go, the minute you hit that door of the ICU, you cut that cord. There's no reception of all that information, and I'm focused on the patient. And also within the healthcare system, there are conflicts because of lack of knowledge about this whole pandemic and the disease. We're learning as we go. I use this all the time. We're learning how to fly this plane while building it. That's not easy for you as a nurse. You're a perfectionist, and it's hard.
Mm-hmm.
So, Salah, I want to tie again some more issues together here and get back to a little bit of the regulatory issue and implications based on what you're telling us and our listeners. So we were discussing earlier about infection control practitioners. They're kind of being distracted by all the demands of COVID-19. They're kind of being pulled away from this whole oversight where they otherwise would be assuring that the sanitary and clean environment is provided under the roof for the patients. And we're talking about how a recent paper you read is showing that HAIs, or healthcare-associated infections, are increasing despite the number of procedures decreasing. So I want to then take that conversation into a database that we call the Adverse Event Database, the MAUDE, M-A-U-D-E, FDA database. And I've been doing a lot of extensive reviewing of that database, and I'm finding a surprising result that seems to be inconsistent with what I said earlier. If the infection control practitioners are so distracted and the number of infections are presumably increasing, when I read the MAUDE database to look at infections linked specifically to contaminated instrumentation, or let me say even deadly bacterial outbreaks linked to inadequately cleaned or reprocessed medical equipment, I'm not finding as many of them in the last year or two compared to previously. So in other words, specifically with regard to the U.S., can you comment a little bit on that? One would think by reviewing the MAUDE database that actually the number of infections might be decreasing. We know that's not the case. So from a regulatory standpoint, are there outbreaks, deadly outbreaks going on each day, specifically bacterial superbug outbreaks that are possibly being overlooked? But when I say overlooked, maybe they aren't being discussed in the press, but they appear maybe not to be sufficiently reported in the MAUDE database. Can you discuss that a little bit as to how the MAUDE database, which provides trends for us, how accurate it is, or is it being kind of put in a back seat where otherwise reports that should be filed aren't filed, and that there isn't really sufficient oversight to make sure that we do comply with the adverse event reporting regulations because of overworked staff, in large part due to the COVID-19?
This is a great question. This is actually, I can spend another hour about how we don't have one database. So the FDA has its own database. The FDA approves devices, and then they follow adverse events with devices. So then there's the CDC, which is an agent of CMS, where infection preventionists report healthcare associated infections. And I'll give you an example: a urinary tract infection associated with an insertion of a Foley device. So there's the other database. And for us infection preventionists and epidemiologists, we are focused on the CDC CMS lineage more than the FDA lineage, because the FDA is focused on only those devices that are FDA approved. And it's almost, there's a huge disconnect between the different databases. Then if you take, and we always talk about that whole clean and sanitary, this is actually should be changed.
You talk about that disconnect, and it makes me think about what happened leading up to 9/11 and how the CIA and the FBI were not conversing. And if they had combined that information, would have likely, not guaranteed, but likely thwarted the attack on America with the Twin Towers, right? Is that the kind of, sort of inter-organizational, is like, because they said that there was a dynamic, right? Everybody said, hey, the FBI and the CIA, it wasn't that they just didn't talk. They also kind of had a slightly confrontational, or I don't know if confrontational is the right word, but they were not collaborators. There was a little bit of a competition going on there that actually, also exacerbated that lack of communication. Do you feel like that same thing is occurring here in the point you just made?
So good analogy. And I'm not an expert in that part of the world, but I read and I heard about that. I think it's normal to have this disconnect because the focus is different. And I'll use the other analogy is our credit reports. The industry found a way to follow every single transaction. I'm exaggerating that we have, because the goal is to assign a number to you as a person because you're trustworthy or you're not. Whereas government agencies, because there's lack of cohesiveness, and I'm not really attacking the government, nor because I work with all agencies and I respect what they do. And I think what they're doing is right. It's just they are not coordinating, creating a warehouse. So we all have that one place where we can pull a report. And I don't want to forget about the EPA too, because it's part of that clean environment.
Great point.
So Salah, when I read the CDC morbidity and mortality weekly reports, in years past, there were always discussions about hospital infections. There was discussions about hepatitis C transmission, maybe due to a bad blood transfusion, or there were discussions of outbreaks linked to contaminated medical equipment. Now, when I read the CDC MMWR, everything is about COVID-19. So can you comment a little bit? You were talking earlier about the FDA focuses more on the manufacturer, point well taken, and the CDC provides more guidance for the healthcare worker. Do you think that the CDC is focusing appropriately on COVID-19, but do you think it's not spending enough time and resources focusing on a plethora of other types of healthcare risks, adverse events, and concerns in hospitals? In other words, has the CDC become too myopic, too focused on only one problem, such that the media following suit with the CDC it seems everyone is focusing on COVID-19 as if there are no other problems in hospitals, such as deadly superbug outbreaks. And we know they are, but the CDC is not discussing them. Can you comment for our listeners a little bit on that?
Actually, correction, they reported on a salmonella outbreak, just for the record.
They were on a national level, but not related to hospital infections per se.
No, but it's just that the focus now, the national focus is COVID. And the volume of cases trumps everything else. Because we're also paying more attention to COVID, we're seeing more of COVID reports. So and I'm not trying to defend the CDC. Their resources continue to be the same, and reporting and investigating outbreaks continues, but it's what's important. And now this is the state of the state. We're still in the middle of a pandemic.
It's more important from a cultural standpoint or from a patient safety standpoint?
Actually, from numbers. In my mind, it's all numbers. When we have thousands of cases of COVID, that's what we're going to focus on. It's very simple. It's a disease that is killing people, and
it's a numbers game. But when you do look at the CDC's publications about the number of antibiotic-resistant bacterial infections killing patients, which, by the way, in a 5-year span will well exceed the number of deaths due to COVID, one might argue a little bit to the opposite of what you were saying, that, again, if we look year to year, it's COVID, but if we look 3 to 5 years, it's not COVID. It's antibiotic-resistant infections. So I agree with you that it's important to focus on COVID-19, but I want to underscore and stress the point that patients dying from other types of infections, they're people too. That's just as important. And in my opinion, I think the CDC should be focusing on COVID, but I think it's allowing COVID to eclipse other type of adverse events, and that I don't agree with.
Again, I'm not sure about the numbers that you have, and I don't have it in front of me. I think if you watch today, there's a national conference for the infectious disease folks, and multi-drug resistant organisms are still the focus. I don't think we lost focus. I think it's just the perception, and it's not just the CDC. I don't want us to believe that the government is the only agency, or all those regulatory agencies are the ones that own the solution. I belong to 4 or 5 professional organizations, and we are all focused on all of the above. So again, multi-drug resistant organisms will never be kind of parked on the side.
Yeah, swept off to the side.
No.
Except my point is, if you just focused on the CDC's current activities and its morbidity and mortality weekly report, you would think that only COVID affects people, that nothing else does.
It's not. I want to emphasize here is that it's not the CDC that actually pushes that paradigm of kind of, we need to stop multi-drug resistant organisms. It's professionals, associations that are experts. The CDC has its function and it supports those activities.
Fair enough, but you do see notes in the field that routinely in the past where the CDC was called in by a hospital to help investigate a superbug outbreak.
And it's actually, if you have a large enough numbers. So the hierarchy of investigation is, first, you as an organization investigate the outbreak. Then you work with the public health department, local and state. You may not need a CDC to help in the investigation. Most of the time, and I was part of an outbreak, actually, I'm going to take you back to 2003, the monkeypox outbreak. When it's a multi-state outbreak, then the CDC intervenes, or when we need technologies that is not available within the local state
and maybe some objectivity
entities.
that they may be able to provide. I agree.
Yeah. So, but they have the experts, and we call on the experts when we don't have them within our sphere.
So, Salah, we're getting close to the end of the interview, but I'm going to tell you, I feel like we're leaving a lot on the table here today. As we often say to our guests, we're going to have to pull you back in and break these down into little chunks. And, from the standpoint of focusing, really on regulatory agencies and surveying bodies and, where there's opportunity for improvement. I think we talked, a lot of the nuance at a more detailed level today, which is good, but also at a very high level, in terms of where the systemic, kind of breakdowns might exist in this scenario. But I want to kind of throw back to an interview that we did with a recruiter in infection prevention who essentially said not a micro level, but at a hospital level, that there's been significant challenges around staffing. And it's because of the same thing that's happening at this higher level, I think, is happening at the hospital level. And we started the interview a lot talking about that. But the truth is we just don't have enough talent. There's not enough resources to meet the demand. And I think what I heard you say throughout this interview was that extends to our regulatory agencies. It extends to our professional trade organizations, because you had a call out there. I heard it. You didn't necessarily go right after it, but there was a call out there. We all have to get involved. If we want these conversations to continue, we're going to have to put in extra time. And I almost feel like there's not enough people to put in the extra time without experiencing the burnout. And so that is why a lot of the professional trade organizations come together and get created, right? It's to augment and fill these gaps in data, awareness, knowledge, training, education, validation from a certification standpoint, right? That there's some competency there. Although there's a delicate balance between certification and competency and not having enough staff. And does that prevent you from bringing professionals in to meet that staffing need, right? So I think one of the things that we can say very globally was that we weren't ready for this pandemic just from a human resources standpoint, period, the end, at all levels, whether it's a government-based organization, whether you're receiving government funding at a hospital, or even if you're a consultant. Probably right now as a consultant, you can't possibly serve everybody that's reaching out to you. You probably have more referrals coming in to your business than you can possibly satisfy. I just can't take it. I'm sorry. Contact so-and-so. They might be able to help you. And it's probably just getting a round robin, where I'll be free in 3 months or I'll be free in 4 months. So with all of that being said, I heard you also say something about surveying bodies and kind of lost our way and possibly creating, and this is going to be me, I'm not even paraphrasing, but creating this false sense of security that because we've passed this survey for accreditation, that's the gold stamp and there's nothing wrong and there's no room for improvement and there's nothing to see here. And that really creates, some concerns. So with just a couple of minutes left in this interview, I want to tie all that up together and just say to you in kind of the final question, how do we get this back on track? Because I think for a lot of people, it just seems like such an overwhelming and daunting task. And I'm assuming you're going to tell me we got to break it down into little chunks, but how do we get this back on track?
I think we have to dig deeper into our souls and ask the patient that question. Ask patients, and not a survey, not a customer satisfaction survey. I'm not talking about that. Not just the inpatient, the outpatient. Ask the nurse and the physician, the provider, the physician assistant, and others who take care of those patients. Ask them. And it's not, you have different entities. In surgery, it's a completely different animal. So I think we need to search our souls for solutions with the ultimate goal is to make healthcare the safest environment ever. I don't think we are, and we are concerned about it. So, and get the experts, the professional organizations involved, but get the patient and those who take care of patients first. And then the last one is coordinate all those efforts by agencies. Why do we have all those agencies with completely different spreadsheets have one system for surveillance and surveys?
So I love it. We don't always end our interviews with, a clear call to action, but I think the time, really necessitates what you're saying. And that, kind of singular source of truth and surveillance would be a huge improvement, because at least everybody would be talking in the same terms. And, I think everybody knows we've kind of gotten to this point, and you see it in global supply chain too. Without standardization, we cannot fix the problems that healthcare supply chain is dealing with, or even just regular supply chain, because, those raw materials and everything, that's all part of the same system. It's just healthcare is demanding them more than ever and doesn't have them. And that has direct impact on public health. Whereas if you don't get whatever you ordered from Amazon, maybe you'll be a little bit more patient about that. So I think you're really talking about, people get scared of big data. So we got to do big data the right way. Great job on this interview today. Thanks so much for coming on.
Thank you. Great talking to you folks.
That was Dr. Salah Qutaishat, infectious disease epidemiologist. And, we started the conversation talking about regulatory agencies and surveying bodies and really trying to shift the focus to the patient and improving patient outcomes, and the role of other professional organizations and their ability to support those frontline workers and really maintain that focus. Because as Dr. Salah said, so many times we wind up hearing from those frontline technicians saying, I'm doing all of this, I'm recording all of this data, but it's not really tied to the outcomes for the patient. And then, of course, we shifted into this experience around COVID-19 and the pandemic. And I loved Dr. Qutaishat's metaphor, kind of talking about a tornado or a hurricane that hit and then just never left, and what that did and the strain that it put on the industry. And of course, Larry dove into the reporting of COVID deaths and the CDC, and finally having one central database for all of this reporting. So great show. That's going to do it for this week. As a reminder, you can help support Transmission Control on Apple, Amazon, or Google Podcasts. You can also find us on Stitcher, iHeartRadio, Spotify, or search for Transmission Control on your favorite podcast application. We also have bonus content for certain episodes. All you got to do is download our smartphone app for iPhone and Android. While you're there, we'd certainly appreciate a rating and a review, because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.